Good afternoon, everyone. My topic is evaluation of retinal nerve fiber thickness in diabetics as an early predictor of retinal damage. Introduction. The number of people worldwide at risk of developing vision loss from diabetes is predicted to double over the next 30 years. So it's important to develop better means to identify, prevent and treat retinopathy in its earlier stages rather than to wait for the onset of vision-threatening lesions. On the basis of vascular changes, diabetic retinopathy is subdivided into an early non-proliferative and a more advanced proliferative stage. Non-proliferative diabetic retinopathy can affect visual function through two mechanisms, that is, an increase in intraretinal vascular permeability resulting in macular edema and variable degrees of intraretinal capillary closure resulting in macular ischemia. There is evidence suggesting that neuronal changes have an important role in the development of diabetic retinopathy and that retinal degeneration may precede visible or vascular changes. Diabetes-associated RNFL loss develops before the onset of the vascular retinopathy, and since nerve fiber layer ischemic changes occur even before the visible vasculopathy changes, it is essential to screen for nerve fiber layer defects and ischemia prior to the vascular changes, as they may help in analyzing the visual impairment prior to retinopathy. Optical coherence tomography has been proposed as a powerful tool for retinal measurement, and it provides detailed information with a high resolution. It also allows the direct measurement of the RNFL thickness by in vivo visualization of the retina and RNFL. Our objective in this study is to prevent the vascular damage to the retina by evaluating the retinal nerve fiber layer in type 2 diabetics who do not have any retinopathy changes. Methods. This is a comparative study between the 30 diabetic patients without retinopathy and 30 healthy non-diabetic patients. Inclusion criteria and exclusion includes age from 30 to 65 years and diabetics without retinopathy, and exclusion with diabetic retinopathy changes, previous macular laser photocoagulation, previous intravitreal injections, and traction effect in the macular area, and refractive errors, retinal vein occlusion, hypertensive retinopathy. Sample size calculation, keeping an alpha error of 5% and aiming for statistical significance of 0.05, we have calculated the sample size and arrived at the above mentioned numbers. All participants provided an informed consent before enrolling in the study, and the complete ophthalmological examination was performed. OCT imaging has been done using the Heidelberg spectralis, and RNFL scan protocol was used to measure the peripapillary RNFL, producing a circular scan manually positioned at the optical disc center with circle diameter of 12 degrees. RNFL thickness was measured and reported as an overall mean, that is global, and by quadrants, whereby quantitative maps of the retina were obtained. Macular scan was also performed to exclude any macular edema. Results: the mean RNFL thickness in the superior, inferior, nasal and temporal quadrants were 119.2, 120.1, 80.6 and 63.2 respectively. The mean thickness was noted in each group in each of the quadrants and was found to be lesser than that of the control population. It is known that the temporal quadrant is thinnest and inferior the thickest, but however in our study there was significant thinning in the study population in the inferior and temporal quadrant. The analyzed data was ranked, and the sum of the ranks were done using the Mann-Whitney test, and the data was analyzed in each of the quadrants. Here in the table we can see that there is a inferior and temporal significant thinning, as in the tables. Discussion, we found that the RNFL thickness in the diabetic population was thinner in all the quadrants as compared to the non-diabetic population. Here the RNFL thickness in the inferior and the temporal quadrants was significantly thinner than the control population. Paul et al. Used HRA-OCT spectralis machine to assess the RNFL in patients with type 2 diabetes and reported that most of the patients with RNFL thinning had temporal quadrant lesions. This is similar to our study. But we also found thinning in the inferior quadrant, which is known to be the thickest of all the quadrants, and hence these results are of more clinical significance. In the study by Mohammed et al., where the study designs were very similar to ours, They analyzed the RNFL thickness in the various quadrants of the retina in diabetic patients with NPDR and without NPDR and non-diabetic patients, and found that RNFL thinning was more significant in the superior and inferior quadrants. These results were different from ours, where we found that there was thinning was more significant in the inferior and the temporal quadrants. The possibility of these results could be because the inferior quadrant is the thickest, and the changes occurring in this area may be the most sensitive to vascular changes when subjected to clinical analysis. Limitations of our study was the small sample size, therefore the results cannot be extrapolated to a larger population, and changes occurring at the RNFL in the OCT may be confounded by age. Conclusion: this study concludes that the RNFL thinning occurs in diabetic patients and may be an early sign of diabetic retinal damage even prior to the vascular damage. The imaging of retinal nerve fiber layer may be an important tool in assessing the diabetes related changes early, and should be made part of diabetic screening. Thank you.
Thank you. Two things you could have correlated it with the duration of diabetes.
Yes.
Because if RNFL thinning was noted in patients who had diabetes of 5 years, and significant, even that RNFL thinning increased at 10 years of duration of diabetes.
Yes.
One thing. Second thing is, you did not mention anything about any subjecting these patients to investigations of glaucoma, because
IOP has been measured and the fundus examination has been taken for these patients, sir. There were no patients with glaucoma in the study.
There is a possibility of bias of confounders actually. Yes. So there could be many confounding factors which can affect RNFL, in non-diabetics as well as in diabetics also.
And at least an angiography was indicated in all these patients to compare it with a standard format which said that there was no retinopathy change. Means we are trying to say that even earlier than the fundus picture of diabetic retinopathy, these changes are appearing. How do we confirm that there are no fundus changes? First is by direct visualization of the fundus, and second by doing some invasive test which has an established role. So fundus fluorescein angiography had you done and said that we did FFA and there were no microaneurysms, there was no change in the vessel caliber, then perhaps, but anyway, good.